afternoon and welcome to the live event on the Delta variant here with Onslow Memorial Hospital. If you are joining, we are just going to give it about a minute for folks to join in on this live feed with Dr. Stephen Spencer and Byron Lee. Okay, we're going to go ahead and get started. So good afternoon. On behalf of Onslow Memorial Hospital, we want to welcome you to our Facebook Live event on the COVID-19 virus variants. Thank you to Dr. Burlingame Deal and the Onslow Memorial Hospital executive team for sponsoring this event, and we're grateful to each of you for joining us today as members of our community. Our guest speakers today are Onslow Memorial Hospital's Chief Medical Officer and Senior Vice President, Dr. Stephen Spencer, and our Director of Pharmacy, Byron Lee. Please feel free to input any questions you may have into the comment section. We have individuals monitoring that, and we'll take some time at the end of our talk to answer as many questions as we can get to. At this time, I'd like to introduce you now to Dr. Stephen Spencer and Byron Lee.
Thank you, Sheree.
Thank you. So I'll get started and then I'll let Byron join in. So I really appreciate everyone taking the time out of their very, very busy day to take part in this Facebook Live. It is truly of the utmost importance that we spend time as the healthcare organization and health system in Onslow County to make sure that we're educating our community about COVID and what's going on with COVID. So as everyone is aware, we've been dealing with this for almost 18 months, starting in March of 2020, when we first realized that COVID was going to be an issue and became a worldwide pandemic. We all dealt with the changing specifications around what we needed to do with social distancing and masking, and really learned together what we needed to do to fight this pandemic. The hospital certainly put into place many processes and workflows to reduce the risk of certainly COVID transmission in the hospital, but also how we were going to deal with patients that were entering our hospital to be treated for COVID. We learned a lot over those first few months, and it was really helpful because in the winter of 2020 and 2021, we really were overwhelmed with the number of COVID patients we had in the hospital. At that time, we had a high of 47 patients in the hospital, which represented over half of the patients that we had in the entire hospital. And everyone really pulled together to make sure we were providing the highest quality care for our patients. So we continued into the spring. We had the vaccines come, which really reduced the rate of transmission. But then we had this testy variant come into play called Delta, which reversed all the good things we had done. And really, we've seen a massive increase in the number of COVID patients in our community and in the hospital in the past few weeks. As of yesterday, we had about 52 patients in the hospital. I think we may be at about 48 today. We have many patients who are in the ICU and severely ill. And of course, you know of family and friends who have been affected by the Delta variant. So we have a lot of great expertise and talent here, and Byron is certainly one of them. As the director of our pharmacy, he has a plethora of knowledge about the Delta variant, about COVID, about vaccines, about monoclonal antibodies. So I really encourage everyone to pick his brain during this Facebook Live and really get a real sense of the knowledge that's out there. I think it's important that you get as much knowledge as possible so we can fight this together and make sure we're keeping one another safe.
Thank you, Dr. Spencer. I think the thing that is important about our discussion today is emphasizing that the Delta variant, which is one of literally hundreds of variants of this SARS-CoV-2 virus, the COVID-19 virus. It is one that has developed a certain set of mutations that make it extremely effective as a viral agent. It is more capable of infecting. It is more capable of spreading rapidly. It has a much faster onset and is very transmissible as a result of some of these mutations that have occurred. So Delta kind of made the treatment of COVID-19 much more difficult when it came along. And of course, this is something we've talked about a number of times here in the hospital, amongst our leadership discussions and in our town hall discussions about just what Delta constitutes and why it is a different ball game. It is something that we look at very regularly. But I think the one interesting thing is that, as Dr. Spencer pointed out, we thought back in January that we were seeing, the worst of it, and we got to a point, as everyone knows, during the spring, as things started lightening up, we started having more people that were vaccinated. We got comfortable with the fact that things were headed in the right direction. We weren't having to wear our masks in as many areas. There were some lightening of restrictions and so on. And then Delta came along, and because of its transmissibility, it made things much more problematic. We're seeing right now, and Dr. Spencer, having, in addition to being our CMO, also works clinically and sees patients here in the hospital. I know you can certainly vouch for the fact that we're seeing, not only are we seeing more cases, but we're seeing a lot of younger folks than what we saw before. And the numbers that we are seeing at this point are actually higher than what we had seen before. And we're anticipating an eventual peak that is even higher. So it does create a challenge. It creates a challenge from healthcare workers who are literally just exhausted at trying to make sure that they are providing the very best care for their patients while continuing to protect themselves from the possibility of infection. And we thankfully do have the advantage of having some vaccines that are very effective. Even against the Delta variant, there is still a very high effectiveness for the vaccines that many of you have received. And a good portion of our message today is going to be emphasizing how important it is, particularly if you have not encountered COVID at all. Believe me, having seen the patients myself, and Dr. Spencer, I'm sure, can tell you even further, having actually interacted and intervened and done his level best to try and bring someone back from very severe situations, made much worse by the fact that, again, we're looking at a younger patient population that is getting it. Part of that is we realize because some of the older folks who were able to get initial access to the vaccine more quickly were vaccinated. And so we're seeing, a younger population from amongst those that, may have chosen not to be vaccinated. And certainly the majority of our patients, Dr. Spencer, are non-vaccinated patients. This concept of having a vaccine and being able to potentially have a very high level of protection from acquiring COVID and from certainly being hospitalized by COVID, and even more importantly, having a percentage rate of somewhere above 99%, 99, I've seen many references to say 99.99. I made a comment yesterday, that's better than the purity of ivory soap. A 99.99% rate in the prevention of death due to COVID. And that's certainly an important statistic, because ultimately we want folks to be protected against this disease, and the last thing we want to have happen is someone be impacted so severely that they themselves pass away or they lose loved ones. I've been in that very boat. I've had a number of relatives and loved ones that passed as a result of COVID, and I think we're all kind of there. It's a very real thing, and as I mentioned yesterday in an email, this is, for most of us, going to be the thing that defines our healthcare careers. Probably impactful for quite a while, and certainly one of the most significant things to come along and impact our lifestyles, our ability to travel and interact with each other. It's definitely something that has created a challenge, and we very strongly want to advocate the importance of vaccination as a very real and effective means at preventing an individual from suffering severely with COVID. Just a little bit again about the Delta variant. The Delta variant has a number of mutations that allow it to be more effective. Compared to the original SARS virus way back when it was kind of isolated to areas in Asia, we would see certain infection rates. We would see instances where the virus was in an activated state somewhere around 10% of the time, and by activated state I mean in a state where it was easily transmissible. So a pre-activated state of around 10%. The thing that happened with the COVID virus, which is the SARS-CoV-2 virus, was that it suddenly was able to be in a far more activated state than the previous original version back in the day. Around 50% of these viruses were shed in an activated state, so that they were very ready to infect human cells. With the Delta variant, its combination of mutations created a 75% pre-activated state, and I kind of refer to it as it's kind of like a bagel. If you get a bagel that hadn't been pre-split, it's a little bit difficult to get in there unless you got one of those bagel guillotines. But if you've got a bagel that's been split, it's much easier to open up and get to where you want to get to put on that cream cheese or whatever you need to put. These viruses have a very similar situation in that the portion that has to be open for activation is already in a pre-split condition. It's already partially open as a result of the action of some enzymes in the human cell. So Delta is, again, we're moving from a 50% activation to a 75% activation. That's a 50% increase over where it was. And certainly our fear is that there is a potential for future variants to be even more problematic. That is kind of the nature of viruses. They mutate. We're all familiar with the influenza virus, which has the capability of completely changing its outer structure as often as every 6 months, but usually about every year you get a complete change. And as a result, we know that we receive flu vaccines on an annual basis. And there is a likelihood that with COVID, that because it mutates, we will see that each year, maybe if we're lucky, each 2 years, but it's looking more like every year at this point, that you may see a reformulation, just like with the flu vaccine. Again, that whole concept is to try and stay ahead of the variants so that you have the very best coverage that you possibly can have. So right now, again, just kind of to bottom line it for everyone, the vaccinations are the most effective thing statistically that you can do right now, today, to protect yourself from COVID and certainly to prevent serious outcomes from COVID. Finally, I know we will have potentially questions from our listeners and viewers regarding this whole concept of boosters. We already just discussed that boosters are something that we feel are necessary. This is not something that's unusual for a vaccine. You know, if you go out and you step on that piece of metal or whatnot, you come into the ED, one of the first questions they ask is, when did you have your last tetanus shot? The reason they ask you that is because they want to protect you from tetanus, and if it's been long enough, they're going to give you another tetanus shot. We've talked about the flu vaccine, which we get every year, and then there are a number of other vaccines that require boosters on a particular schedule. The hepatitis B vaccine requires 3 doses to be fully activated and effective. So we right now have a COVID vaccine. One, of course, is a single dose. 2 of the vaccines currently available are 2-dose vaccines. And it is likely that boosters will be recommended when we hear from the final decision making sometime around the 3rd week of September. But again, that is a process that's expected and something that is very normal for when you're dealing with vaccines. And I think again, the best decision that you could make at this particular juncture is to move forward with being vaccinated if you have not already been vaccinated. And so with that, I'll kind of allow Dr. Spencer to get a word in, or if we
I
have
don't need a
questions in
word.
one.
But if you have questions, great.
I talk a lot.
No, that's why we love Byron. He's has lots of knowledge, and I love actually listening to him.
Thank you.
So we do have one question here about variance. You mentioned variance, and there is a question about variance of interest versus variance of concern. Can you clarify what the difference is between these?
Absolutely. So a variant of interest, again, we probably, I hesitate to say this because I don't have specific statistics, but I would say that there is very little doubt that the COVID virus is one that is being studied probably more intently than any particular virus at any particular given time historically. It is being examined very constantly to determine if there are differences between, let's say, a culture that was done 3 months ago versus a culture that's done today. It's an ongoing process, and it is being constantly examined for these changes. So on occasion, we have been able to identify certain changes where in the viral strand, one particular nucleotide has been substituted with another. So you might have a proline substituted with an arginine, and that change, that small change, has been determined to provide an advantage. Either it makes the virus potentially more difficult for antibodies to recognize, which is something that happened with the Delta variant, or it makes the virus easier to activate, which is something that happened with the Delta variant. So we can identify these changes, but the net result is that it is a combination of all the mutations that have occurred at any given time to actually enable the virus to do what it can do. I kind of make this analogous. If you happen to be a mechanic on in a race car team, You might make a small change to the way the fuel injector is working. You might add a little bit of a different kind of process. Maybe you've got some nitrous or whatever that you add. But in the end, is that going to be the race car that wins the race? You don't know. You make the changes, you maybe change the tires, whatever the case may be. It's a combination of things, but winning the race is actually the goal, and you may or may not. When we say a variant of interest, what we mean is that virus, that particular strain of the virus, has mutated in certain ways that we think are going to give it an advantage. But at the moment, we don't necessarily see that strain is being spread more widely, or that it is more difficult to identify, even though those genetic changes in particular places have been identified. That's called a variant of interest. There's a change that we think may create issues because it's been known to do certain things in other variants. Where it becomes a variant of concern is when those changes actually pan out. And what we see is a virus that with its particular set of mutations, I believe the Delta variant had some 13 identifiable mutations that were thought to be advantageous. And as a result, that particular strain becomes the dominant strain. That's what happened with Delta, and if I remember correctly, somewhere around 98% of the strains right now are Delta variant. And even knowing that Delta variant in its particular incarnation was extremely effective, there are yet 3 more variations on the Delta that we've been able to identify as potentially even more problematic. So a variant of interest, we've identified specific things that could be a problem. A variant of concern, we have actually seen greater infection rates or higher spread or more difficulty in identifying it.
And I think one of the things that you brought up previously was the Lambda variant, which was more of an interest. We have not seen it be a concern as of yet, but we're keeping a close eye on it.
That's exactly right. Lambda is a perfect example of one that we're looking at because we see literally a section of the virus that has mutated somewhere around 10 to 15 of the nucleosides have actually changed. And that larger change theoretically could produce a strain that is less susceptible to antibodies because, again, it's more different than it was before. At the same time, we've not exactly seen a tremendous impact of that identified change. We've not actually seen, Lambda be quite as effective as Delta. And so, again, it was of interest. It's still of interest. We think it could be problematic, but it's not panned out quite yet. We also have variants like Epsilon that have been identified and they thought they were going to be problematic, but the infection rate has become so low that they're no longer even a variant of interest because they're just not panning out based on what we thought they might do.
Thank you. So the next question is, how do variants develop? Do they change with each transmission from person to person, or is it some other process?
So Byron is really good at answering this question, but I think one of the things I'm just going to highlight again at the beginning is the more folks that are getting COVID, the more likely the COVID virus is to mutate. So from a public health perspective, that is one of the reasons why vaccinations are so important. It's important to the individual so they don't develop COVID, but also it's important on a bigger scale because the more folks who keep getting it, the more likely that virus is to find something that's going to stick. And then Byron is going to explain that in a little bit more detail, but I wanted to make sure we recognize that piece of it.
Yeah, it's absolutely essential to realize that the larger the number of people who are having it, because we each respond to the virus in somewhat unique ways, the more chances there are of the virus becoming different, because the viruses that we're able to anticipate and attack appropriately with our immune system are not the ones that are going to survive. It's the ones that are different. It's no different from any bacterial infection that you might have, and we even have bacteria in this day and age that doesn't even respond to any of the antibiotics that we have. The problem with viruses is they do not have, and of course I'm sure some of you already are aware of this, they do not have their own capability to replicate. Viruses, although they do consist of genetic material like RNA in the case of the COVID virus, some are DNA viruses, but they do not have an ability to replicate, and so they are dependent on the host cell, in this case a human cell, to do their replication. And in that process, unlike human cells, which are very complex and have multiple redundant mechanisms for correcting errors, the viral process does not necessarily have that error correction to keep things moving along the appropriate lines. And as a result, small changes will occur because there's not a whole lot of corrective ability in that strand of RNA that's produced, and eventually the proteins that result from that strand. So it is very common with viruses. They're again, because of this lack of a corrective ability, like most animal cells, they have a very high propensity for mutation. Some of these mutations are going to be problematic. In other words, they could literally stop that particular strain from moving forward at all, and the virus dies out. Or, as we mentioned, there is the right combination of errors to make something entirely different, and in some cases, much better at what it does.
All right. So Valerie is asking, how soon can a COVID positive person get vaccinated?
I think that's a great question. Byron had a great answer to that. So in the beginning, we gave sort of a general idea of 90 days, just because we didn't really know how long you could wait after being infected. But that probably is not an absolute. And what we know for sure is that getting vaccinated, even after being infected with COVID-19, really decreases your risk of getting COVID again. So it's really important, even for those folks who have been infected with COVID-19, to get the vaccination. There are numerous studies which show a huge decrease in getting infected, and certainly severe infections that require hospitalization if you are a patient who's had COVID and then gets a vaccine afterwards.
Yeah, very recently a Dutch study was published that demonstrated that individuals who were vaccinated had a much greater chance of A, surviving a COVID infection, and B, having much milder symptoms. As Dr. Spencer mentioned, originally there was kind of this 90-day concept, and the reason for that 90 days is because it was felt that it would take about that long for the antibodies produced whenever you got actual COVID. It would take about that long for those antibodies to diminish sufficiently that it was safe for you to get the vaccine. Why is that? The vaccine, again, causes your body to produce antibodies, and if you're already producing your own antibodies and recognize those spike proteins that are formed when the vaccine has its effect, there's a possibility that you could have an allergic reaction or reaction to something that your body has perceived as a threat, or what we call an antigen. So it was felt that 90 days was just a good amount of time to wait for those antibodies to die down a bit so that we could not increase the possibility of a reaction to the vaccine. But we know now that, as a rule, generally, once the symptoms of COVID have abated, it is safe and appropriate to receive, to start your series of vaccinations at that point. Even if you have already had COVID, maybe you had COVID back, months ago, And some people feel like, well, this is going to help your immune system to resist, future COVID. And it is conceivable that it may help somewhat. At the same time, we definitely know that the antibodies associated with what, as your body produces those antibodies to real COVID and the vaccine, over time, they're going to decrease. So even in that instance, just as we're talking about possibly receiving boosters for our vaccinations, in some ways, receiving the vaccine, initially receiving the vaccine after having acquired COVID and gotten past it, and that's the important part, getting past it, may act as a booster to your immune system. It certainly improves the chances that you will not get reacquire COVID, which we know is a possibility.
Okay. And are there any special populations that should or should not get the vaccine, in particular pregnant or breastfeeding individuals?
So this was definitely, I think, a concern in the beginning, especially pregnant women. I think was maybe one of the more controversial populations, because of course we're always concerned about anything that could affect the pregnant woman, the fetus, and certainly any sort of long-term effects. But what we realized, again, after extensive research, is one, that the vaccine was extremely safe in pregnant women. We did not see any increased adverse effects in this population. And number two, the risk of getting COVID, both to the pregnant woman as well as to the baby, were much higher than any adverse reactions we were seeing with the vaccine. So this is definitely a population that we want to make sure that they're getting the message out that they should be getting vaccinated. This is the same message, by the way, we had to get out with flu. Same message we had to get out with tetanus pertussis as well, that pregnant women are at higher risk of these illnesses. And when they get these illnesses while pregnant, it actually puts the baby at a higher risk. So it's really, really important that pregnant women get the vaccine. The vaccine is safe. We have not seen any adverse events specifically for pregnant women.
Yeah, I definitely think that is well supported by what we literally see in the real world. These vaccines have been used in hundreds of millions of individuals in a number of walks of life and a number of health situations, particularly individuals who are high risk, and pregnancy is considered a high risk category, certainly for getting COVID or being severely affected by COVID. One of the other advantages of potentially getting the vaccine while pregnant is that you may actually pass on some passive immunity to the child. To provide an additional level of protection, once it's born, that would not otherwise be there. Just as it's important to breastfeed and pass on. I know that's a concept that Cherie is near and dear to her, being a OB nurse for years. That is so important with breastfeeding, and again, it's something that is an advantage in receiving the vaccine, while pregnant. It's been shown to be very safe, and we even had providers, actual physicians here in the hospital, as well as a number of our own employees who made the decision to get the vaccine while pregnant. And things have gone very well for them as far as their tolerance and no indication of any problems caused by the vaccine.
And pregnant women were excluded from those initial studies when they first did the first cohort, only because they were being very, very cautious. But even in those initial studies, there were women who did not know they were pregnant who were part of those studies, so they were followed very closely to make sure there was not an increased adverse event rate in those patients.
Those individuals were, as Dr. Spencer alluded, they were pioneers in certain ways in being vaccinated, and the information gathered from their vaccinations and the positive outcomes that resulted were part of what's inspired individuals to start looking more closely at, should we use these vaccines in pregnant women? And it looks like it's safe. Let's see what we can find out. And of course, those studies have been done and looked at, and again, probably one of the highest test phases, so to speak, if you want to call it that, during the emergency use authorization for these vaccines of probably any single medication ever released for all time. So a very, very safe product. When you look at the actual, folks that have been vaccinated who are, pregnant or breastfeeding, and they've had very good results having received the vaccine.
What is the significance of the FDA approving the Pfizer vaccine now as opposed to their original emergency approval last year?
So I'll always start, and Byron will then fill in the pieces. So the emergency use authorization is something that we give pharmaceutical companies for cases just like this, when there is a worldwide pandemic, a public health emergency, where we need to fast track a medication that we think will save lives. And that's what happened with these vaccines. So we were able to put in that emergency use authorization because we had studies that had been going on for several months that showed that it was efficacious and safe. So then what happens is we're able to use the emergency use authorization, people get the vaccine, we continue to follow the original group who are in the control studies, as well as now all these millions of people who have gotten the vaccine in the real world. And then what the FDA will do is they will go and look at every single study from the original control trial. They actually look through all the numbers. They have, I think, hundreds of people who are diligently testing the numbers, making sure everything is right, scrutinizing everything. They look at all the ad hoc studies. They look at all the real world studies. They look at all the adverse events that are reported. And then based on that now more rigorous research, they decide whether or not it should be fully FDA approved. And usually what happens, and what happened in this case, is the CDC made a recommendation, and now the FDA and then the Advisory Committee on Immunization Practices will go in and make the official recommendation based on all of that additional scrutiny of the original research and the ad hoc studies, and then an expert panel who will make that final recommendation.
Let's bear in mind that the FDA is one of, if not the most well-respected drug regulatory body in the world. There are a lot of eyes that fall on the FDA when they approve something. In this case, and as always, the FDA wants to make sure that tests and actual human studies demonstrate safety, efficacy. Normally we start out in small phases where we have small groups of people, but as Dr. Spencer pointed out, this was a situation where a drug appeared to be safe, it certainly appeared to be effective, and if there was anything we could bring to bear to stop the spread of COVID, it made sense to move forward with whatever that thing might be. And in this case, a well-designed vaccine. Ultimately, 3 have been released in the United States. But the important thing is that placing that final approval means a lot of things. It is almost a guarantee. Now, of course, sometimes all those studies, particularly when we're talking about studies that don't involve millions of people, but only a few thousand or even a few hundred, may not necessarily demonstrate the fullness of what could happen. The smaller the sample size, the more chance that sample size was not large enough to catch odd or unusual or rare reactions. But this is, again, as we talk, this is one of the largest sample sizes that has ever been, a drug has ever been put through. And so after having that, instead of taking, years and years and years, this was a drug that could be developed very quickly because of the technology itself, could be tested in multiple phases simultaneously as a result of how these drug companies were working cohesively and together with our government and governments throughout the world. And ultimately, the final approval was that seal that said, yes, we agree that this drug has demonstrated itself to be safe and effective, and we are willing to put our stamp of approval, so to speak, on that. it opens the door to possibilities, particularly with this mRNA technology, that have, again, not even been thought of before, and yet now we're seeing things even up to and including an HIV vaccine, which is unprecedented, but we're seeing things coming down the pike as a result of this technology and its development and study and tests throughout the world in a huge sample size population.
Has there been any information about when younger kids might be able to get the vaccine?
I'll let Byron take that one.
Well, I can tell you that is something that is being studied. Again, with younger folks, where we generally don't see the kind of symptoms we see with older folks, unless we're talking about a child that may have maybe a developmental disorder, or maybe certain genetic factors that predispose that child to problems. Not just from COVID vaccine, but from any medication. Certain groups, of course, have that predisposition. It is something that is being studied, but you will note that it is, again, these younger children are the group that they're most interested in making sure that, we not only are we looking at safety and efficacy, we've established it throughout the populations that have been tried, but it is very, very seldom that the first ones to try any medication are the children. That absolutely is, they want to assure themselves, and testing is being done along those lines. I have not seen any specific information about when it might be released for young children, very young children, in other words, under 12 years old. But I will say that testing is being done at this time, and based on the release rate, as you know, we saw individuals over 18 that were authorized for the vaccine, and then we saw it drop down to 16, and then now we're seeing recommendations for ages 12 and older. So I think we will, in a relatively short amount of time compared to what you would see with other medications, because of this large sample size and because of the focus on trying to eliminate a pandemic, a worldwide phenomena, you will see something happening, I would say, in the near future.
Yeah, and so certainly we know kids can transmit COVID. We know they can get sick, of course, at lower levels than older populations. But what we're seeing now with the Delta variant, we are seeing the highest levels of pediatric hospitalized patients that we've seen during the entire pandemic. So while the risk still remains relatively low, it's higher than it's ever been. And I think probably the bigger piece of this is really, again, decreasing that transmission for the entire population, because we know kids carry it, we know they spread it. They may not be, they may be less likely to die from it than older people, but certainly they are carriers and can spread the virus around.
Yeah, I think that's a very good point. And again, we're seeing these younger populations in part because the older populations were the ones that were the first vaccinated. We're seeing large groups of vaccinated people in that category, but some of the younger folks, of course, now remain and can be carriers or even acquire COVID and have more severe symptoms.
So the follow-up to that is many people are scared to receive the vaccine because it was developed so quickly. Can you explain the process of how this vaccine was developed and how quickly it may or may not have been developed?
So Byron's going to tell you it was not really developed quickly. It's been around for years, right, Byron?
Absolutely. Since the concept of using mRNA in a liposomal container, so to speak, which is what the vaccines are, at least our mRNA vaccines, has been around since the 60s. This is something that has been looked at, it's been theorized, it's been talked about, and this is one of those occasions where it's actually been put into practice and been demonstrated to be effective. Moderna itself, its name is literally derived, the M in Moderna and the last three letters RNA, it's derived from mRNA. That company based its whole philosophy on developing mRNA solutions to diseases and viruses, etc., worldwide. They have a scope that they're hoping to develop more effective products through the use of this mRNA technology. Again, RNA it's like a piece of code. You are not waiting for the viruses to grow in chick embryos or in chimpanzees or other animal hosts. Cultivating that, figuring out what media works the best. You're not having to wait for all that. And of course, even polio vaccine is a vaccine that's passed through animals, and then certain versions of the polio vaccine pass through animals, and then the organs are collected, and it takes time to do that. For the mRNA vaccine, literally, because the actual sequencing of the COVID virus vaccine was released by scientists in China who were studying it, because it was released and readily available, Moderna was basically able to design their mRNA vaccine, which duplicates just the spike protein portion of COVID, over the course of a weekend. It was very easy to program in this code, this code, this code. It was very easy to scale up with the production methods that they have, because again, they're not growing viruses, they're producing specific genetic code, and it can be done relatively quickly and scaled up relatively quickly. So the design itself was very quick. Normally that takes years of effort in and of itself. The design happened over a weekend. And then all that was necessary was to put that design to test. And of course, as we mentioned, because they coordinated with government resources, they were able to do multiple phase testing. What would normally be, well, we have to do this phase, and then this phase, and then this phase. Instead of having to do them sequentially, they were able to do them simultaneously. And so the end result was a product that we knew or felt very confident would be effective, but its design was quick because we already had the code, that particular sequence, for the entire viral genome, the entire section of RNA, some 35,000 plus nucleotides in that sequence. We knew the whole thing. We knew what part was the spike protein. We knew what part was the innards. We knew what part was the envelope. We knew what part was every single portion had already been mapped out. And that in itself takes a long, long time. And the fact that it was already done made it that much easier to design this vaccine. And again, it is a new concept from the standpoint of being used as widely as it is. But it is not new with regard to this methodology. It's been around since the 60s.
Thank you. As flu season nears, should I continue to get my flu shot as well as the COVID vaccine?
Yes, yes, and yes. So what was interesting about last year, before we had the COVID vaccines, there was a lot of discussion about this idea of co-infections. So, God forbid you would get COVID at the same time that you got the flu, you would be more severely ill, more likely to be hospitalized and critically ill. The good thing is that people heeded that warning, and many people got their flu shot very early. But probably what changed the trajectory of that whole situation is really that we were socially distancing and wearing masks. So our flu season was very, very minor, probably the lowest flu amounts that we've seen in decades. And so we did not see a lot of that co-infection. This year is a little bit different. So this year we have relaxed restrictions. We are no longer socially distancing the way we did. People aren't necessarily wearing their masks the way they did a year ago. And so it probably is even more important that people receive their flu shot this year. The other piece of this is that because, one, if you didn't get the flu shot last year, or two, if you weren't exposed to flu, now you have a 2-year gap. And what happens with the flu is that there's actually a sort of a building immunity. So the more you get the flu shot every year, the more likely you are to get more protection from the flu, which is why there is a sort of a soft recommendation for children under 8, if they have not received the flu shot, that they actually get 2 doses within a season. So I think with those things said, because we did not have a flu season last year, a lot of people weren't exposed to the flu. I think it's even more important that people get the flu shot this year. Now, the next question, and I'll maybe leave that to Byron, is when should you get the flu shot, and in what temporal space should you get it in relation to getting the COVID vaccine? So that'll be something we work through. There's no clear contraindication to getting them at the same time, but I know some people like to space them out because they may have some minor side effects with the COVID or the flu shot.
Definitely so, and I think, again, there is not an absolute consensus with regard to when to get them. We certainly know that flu is most commonly encountered during specific months. Generally, we like to say sometime in the September-October timeframe you should get your flu shot, so that it gives you protection during the time when flu is at its height. Flu's always around, but knowing that it's going to be more predominant during a specific time frame, that's why we say get your flu vaccine during that particular time frame, and that's when the new formulations are released. There's a lot of thought that says you can get them simultaneously, maybe go ahead and get all the side effects over with right to start with. Many people who receive the flu vaccine have no side effects at all. Many people who receive the COVID vaccine have no side effects at all. Even the second shot sometimes, oftentimes in fact, they have no side effects at all. But there is a possibility. I actually received my second injection, and I got a little feverish, got some aches and pains, basically kind of like a mild case of maybe the flu, or maybe a cold, just achy pains and that kind of thing, which resolved within about a 12-hour period. Again, the thought process is, well, if you're someone that reacts to the flu vaccine and you normally kind of get that malaise and the aches and pains and the fever, chills, whatever with flu, and you react to the COVID vaccine, it might kind of add together in what we call a concomitant effect that would be problematic. So spacing them out, may make sense. But again, let's remember that the side effects, these particular side effects, generally resolve within about a 12 to 24, certainly by a 36-hour period. Those side effects are non-existent. So even if you say got your flu vaccine this week and your COVID vaccine next week, that would certainly be feasible if you are worried about potentially having an additive effect from both of those vaccines simultaneously.
Thank you. So I think we have time for one more question, and that question is about the booster. What are the current recommendations for the booster, and when can we expect it in Onslow County?
I'll let Byron.
Okay. So there's two things that people some are calling boosters, but they're not really necessarily the thing that's booster. So I'll start with the first, which is the here and now. Right now, today, there is a recommendation that any individual who is immunocompromised. What does that mean? That means that you are potentially taking a medication, or that you have an ailment that keeps your immune system from responding as fully as an individual who was not taking that medication or who did not have that particular ailment. For instance, if you are receiving chemotherapy, acts on, just as it's acting on those cancer cells, it acts on your white blood cells, red blood cells, any cell that's producing at a rapid rate. Certain chemotherapies will act on those and diminish your immune capability. If you're someone that has received an organ transplant, the medications that you take suppress your immune response so that you don't reject the organ. But as a result, as you well know, being an organ transplant patient, you have to be very careful about going around large crowds. There's even recommendations for this group to wear masks in specific situations because they are more prone to infection. And of course, an individual who has the HIV virus, it would be in an immune state that could potentially be suppressed. Now, why is that an issue? It's an issue because when you receive the COVID vaccine and your immune system is suppressed, you may not have as strong a immune response, maybe not get the full antibody buildup that you would expect from an individual who was otherwise healthy. So right now today, there is a recommendation that if you are one of those individuals who potentially has immune suppression, and certainly talk with your primary care provider to find out if you think you are in that category and are not sure, but the recommendation is that you get a third dose, an additional dose of the Pfizer or the Moderna vaccine, preferably the same brand that you received originally. There's not a specific guideline for the Johnson & Johnson vaccine, which you know is a single-dose vaccine, but that is being looked at and may be a recommendation in the future. But right now, the recommendation is for immunocompromised individuals to receive a third dose so that they can get additional immunity build up because their immune system maybe did not respond as adequately as it should have. Now, the concept of a booster is a little bit different in that there's a couple of different things kind of floating around as to what we should give as a booster. Should we give the same dose as we gave before? Should we maybe reduce that dose because individuals who responded strongly before may respond, in an overstrong way to receiving the same exact dose? Should we perhaps have a formula that takes into account, like we do with the flu vaccine, it takes into account the newest strains? And I think at some point that is certainly a likelihood. Again, with the short time frame that they're looking at, which is, we've been told somewhere around the third week of September, there should be a recommendation with regard to what that booster should be. What should the dose be? What should the contents be? The formulation, that is. It is likely still that you ideally will get the same brand that you got before, so that there is a continuity of the immunity that you've been able to build. However, again, we may know that answer on the third week of September, but it may be, particularly if the answer is, you really need to have a formulation that has these new variants to most effectively cover these new variants. If that is a recommendation, it may not be until a bit later before we actually get those boosters. Now, a recent a recent article in the Wall Street Journal implied that generally after about a 6-month period, some sources say 8 months.
I heard 5 months today.
I was going to say you probably need to think about a booster simply because, again, you ask yourself, well, I'm immunocompetent. I've had my responses and I should be fine, right? Why do I need a booster? Well, again, as we talked earlier, over time, that immunity, those antibodies start to dissipate, the immunity starts to wane because you're not being challenged by it any longer. And this is no different from many, many other vaccines. Some last longer, some last shorter, but it is something that we anticipate could very easily happen. So getting that booster shot just kind of pumps your system up a little bit more by adding some extra protection, as your immunity starts to diminish. The same as we talked about it could potentially do if you have already had COVID. Getting that vaccine is going to pump your immune system up even further. So it is again doing just what it says. It's boosting your immune system. Some sources say you are still very, very well protected after having received your second shot of either Pfizer or Moderna, and even the J&J vaccine shows very good effectiveness against the Delta variant, even more so than in the original variants. However, again, it remains to be seen what the recommendation will be, and we're still anticipating around the third week of September before we know for sure what direction that's going to take. So I would say certainly not until towards the end of September would we possibly see boosters, and maybe a little bit longer if the recommendations are towards a reformulation.
All right. Well, we want to thank Dr. Spencer and Byron for joining us today to share their expertise on a topic that continues to evolve. We appreciate everyone for joining and also for the great questions we received. If you have further questions, please leave them in the comments and we will get those answers to you as they become available. Dr. Spencer or Byron, do you have any closing comments that you would like to share?
Just want to take a minute to impart a little bit of wisdom for folks. So I think one of the things that we talked about a lot, especially in the beginning of the pandemic, and then certainly when we got the vaccines, is about efficacy. So we heard these numbers thrown around about 95% and 94%, and now we hear slightly lower numbers thrown around. We hear about breakthroughs. I want to stress again that even without the booster, the vaccines will provide a level of protection that's really unprecedented in the history of vaccines. And when you're looking at those efficacy numbers, and now efficacy is in a controlled trial, effectiveness is in the real world, you're not looking at them the way I think most people think about them. I think I was probably even thinking about it this way. So if I get the vaccine, and I got the vaccine in January, it was 95% effective, or had 95% efficacy, so now I'm 5% likely to get COVID. No. That means if I have the vaccine, I'm 95% less likely to get COVID than someone who doesn't have the vaccine. And I think that's really important. Even if it goes down to 80%, you're 80% less likely to get COVID than someone who doesn't have the vaccine. And again, we are seeing that in our hospital right now, in the real world, where our sickest patients are the patients who did not get the vaccine. The other point I want to drive home is risk assessment. So everyone over the next few weeks, the next few months, you're going to have to make some risk assessments. It was easy a year ago because the government was basically telling us what to do. You can't go here, you have to wear this, you have to do this. Now, it's pretty much carte blanche what we want to do, but you have to make a risk assessment. Do I want to go to that indoor facility with thousands of people who may have COVID and not wear a mask? So your risk is going to be high on the spectrum. Your risk is much lower if you've been vaccinated. Your risk is much lower if you wear a mask indoors. Your risk is lower if you're outside. So every time, unfortunately, this is the way it is, every time you make a decision about the things you're going to do over the next few weeks or months, it's not a either or, a yes or no. There's no absolute here. It's going to be on a spectrum of risk, and you have to make a decision, is that risk worth it, and what kind of risk do I want to take? And again, go back to the vaccine, that's going to send your risk down in that risk spectrum no matter what you decide you're going to do with those other events.
I definitely agree with Dr. Spencer in that regard. And I want to also add, if you think about it, the best thing to do right now is to protect yourself as effectively as you possibly can. That is the key to being able at some point, hopefully in a near future, where we are not having to be so concerned with COVID, just like we are not overly concerned about smallpox or the various other diseases that have been reduced by so much that the encounter with those is almost non-existent. Some of them non-existent, some of them just, there's a few pockets that remain, but protecting yourself effectively now, getting the vaccine now, is our key as a society, as a world, to being able to move back into a more normalized state where we can enjoy each other's company and those things that we've always enjoyed throughout life. That's the key. And we've got to make that decision, as Dr. Spencer said, to either reserve now, and if we don't, it's going to take a lot longer to resolve.
All right. Thank you, gentlemen, and thank you for all sticking through and watching with us. Have a great afternoon and stay safe.
Thank you.
Thank you.